Thromboprophylaxis in total hip replacement can be very confused. At the left, you can see the different drugs which can be used for our treatment program, including the very new oral anticoagulants. And on the right side, some of the issues which we still are discussing. What are the duration of the treatment? When should we give the first dosage? What about patient comorbidity? Does that mean anything? Does it mean anything if the patients had a shorter stay in the hospital, and even if they're mobilized very quickly after the surgery? And some of the other things which we still are discussing, what about safety of the different drugs we're using, and the new drugs coming in, there are no antidote, what to do about it? All of us are used to work from international clinical guidelines, and among here you can see that CHEST are the guidelines which all of us are looking at here in Europe. At US, they're also looking at the AAOS guidelines, but in Europe we are more or less looking at the CHEST guidelines. These are the latest one coming out in 2012. They review them in between, and I'll come back to that later on. But so if we take a look at the DVT prophylaxis, it's a fast-track setup. If we take a look at the American College of Chest Physicians, they create their guidelines from studies where target was to minimize the venographically proven DVT, where the majority of them are asymptomatic. Some of the studies are of older days. They look at randomized studies with a very large number of total hip arthroplasty. But lengths of stays in these studies are up to 12 days, and they frequently do not mention about mobilization. And we, as orthopedic surgeons, we really look for studies for symptomatic DVT, and we look for data on today patients. That means the minor spinal anesthesia, mobilized few hours after surgery, and with a very short length of stay. This is my clinic in Denmark, in Vejle. We have been working with rapid recovery joint program for many years. Here you can see that we, over the time, this is the graph to the right, we have working up to about 600 primaries per year. And to the left, you can see the average total hip arthroplasty per 100 inhabitants per year in Denmark. We are close to 160, which are more or less what it is in the Nordic area. But in the same period, our length of stay has decreased dramatically. So we today, at a primary total hip replacement, have an average length of stay of 1.8 days. We tell our patients at the patient seminar that they have to go home very early after surgery, and we tell them you will only have DVT prophylaxis as long as you're in here. The patients are admitted to surgery on the day of surgery. Each of our theater are doing between 3 and 4 total hips. They have what we call a low spinal anesthesia with a PACU treatment, which I think is normal, phenterline and oxycodone. We use standard incision. We use the posterolateral approach, continuous suturing of the fascia, and no drains so that they can get mobilized immediately after surgery. They stay in our PACU for about 1 to 2 hours, and they're mobilized, all of them, up of the day nearby, because here you can see our figures. That is both hips and knees, that we are very close to 100% getting mobilized on the day of surgery. And of course, you cannot be 100%. There will always be patients which cannot be mobilized. And they are going home very quickly, as you can see. In selected cases, and this is rare, but we have them, they go home on the day of surgery. We have a minor outpatient program for these cases who come to us and ask for getting quick home, and they can really go home. The day after surgery, we approximately have 30% going home, and the rest, nearby 60%, day 2 after surgery. This is a big change and a big move in our department. So the question here is, what DVT prophylaxis is really needed for such patients? If we look at the latest version of CHEST, they tell us that we should use treatment for 10 to 14 days, and in selected cases up to 35 days. There have been written a lot in history on literature on DVT prophylaxis. This is only 2 of the latest versions where they summarize about the topics. In the first, the upper here by Barack, he told us that in US there are some clinics who do one way and other clinics do other ways, so it's very confusing what really is going on. And the lower regular article by Selby, that really tells that clinical guidelines are not always followed. It's only about 50% of all clinics who really use the guidelines. In my own clinic, back in 2010, we started with Fragmin, and we used it, like you can see here, once a day from a day of surgery onto discharge with 5,000 international units. At that same time, my colleague from Copenhagen, Henrik Hustig, he published this manuscript here in Acta Orthopedica, where they looked at older data. Come on. Because Henrik and his clinic, they have only been giving DVT prophylaxis during stay in clinic for many years. And if you take a look here, you can see from 2004 to 2008, and this is hips, number of hips, and length of stay. The reduction in stay have been dramatically. And if you go down here and take a look at the THA and the different DVT, pulmonary embolism, and death, these are very, very limited. And this is even better to see here in the slides. To the left is the hip, and to the right are the knees, showing that the number of events is very, very low. On the hips, there were no deaths. There were 2 deaths for pulmonary embolism in the knee area. For that reason, 6 clinics in Denmark, including my own, entered a Lundbeck Foundation research program, where one of the researchers was to look at this DVT prophylaxis, whether it was really needed. This was now 6 high-volume centers. All clinics had a standard fast track set up for total hip and total knees. We looked at all our cases from February 2010 to 2011 who had no prescriptions of any potent anticoagulant therapy over the last 6 months. This was very easy for us to find because in Denmark we have a Danish national database for reimbursed prescriptions, and we could go in there and see whether they have been prescribed some of these drugs. We claimed that they may have no surgery to that same total hip and knee within the last 45 days, and there should be a preoperative detailed questionnaire filled out by all the patients. All of them were followed for 90 days, and again, unique from the Danish National Patient Register, we can go in and see in details where the patient has been submitted to a clinic, not our own, but all clinics in the nation, since they were discharged. And all readmitted and dead patients, their files were observed and looked through. And we wanted to investigate the incidence of symptomatic thromboembolic events with only in-hospital prophylaxis of length of stay less than 6 days. By this, we ended up with 4,900 patients, and of course, this study was approved by the ethical committee, otherwise we could not do it. Prior to the study, we defined these thromboembolic events here. I think they are more or less recognized by all of you, but it's very important when running a study like this, you know exactly what you should look at afterwards. And we had the result published in British Medical Journal Open last year, and the summary is out of the, this is the editor who wrote the summary, the 2 positive and 1 potential drawbacks, which are very clear. The positive thing is it's a prospective multi-center trial, and it completed 90 days follow-up through our national register, but we only recorded these thromboembolic events which we could find in the files. Those who potentially was not in the files, which we don't think is so many, they of course could not be recorded. Busy slides on the flow of the patients, just telling you that there are some patients which went out. We took all the fracture patients out, of course. There were some with severe congenital defects which were taken out. Some had bilateral total hips also taken out. And then some of the procedures was not following our guidelines, and therefore they were also taken out. But totally, we ended up by 4,659, which fulfilling the requirement of thromboprophylaxis only during hospitalization and length of stay less than 6 days. I'm sorry to this very busy slides too, but what is of interest for you is those 2 groups. The early discharge were those who 4,600 would fulfill the requirements, and the unsuccessfully, they had the same treatment, but they couldn't go home on day 6, so they were recorded by themselves. They were mainly the elderly and they also have a higher incidence of comorbidity. And if you try to take a look at any venous thrombosis events, you can see the incidence is very low, 0.41, 0.61, with an acceptable confidence intervals compared to the others, which are only 260, which was relatively high. Any TE, which include all the other things, 0.84, 0.1, 4.5, 1.4, and any VTE or deaths of unknown cause, also 0.54 against 2.6. So these are the results which we, of course, were very surprised on with that they were that low. You can see here some figures on them which really tell you that these events here, in both of them, mainly take place within the first 30 days after surgery. So the conclusion here was that the median length of stay for these patients here was in fact 2 days. They have, by this prophylaxis, by median 2 days. The total thromboembolic event was 0.84%, and VTE was as low as 0.41. And among those who had VTE, 5 had a pulmonary embolism, 14 had real DVT as the only one, and 1 has a fatal pulmonary embolism. So our conclusion in that manuscript was that patients running in a fast-track setup like the present, they have a very low incidence of TE, and they can safely be treated only as long as they are in the clinic. And I'm sorry to this because this is now in Danish, but it's the Danish regulation. We went, of course, with this study, we went to the Danish board and asked them to look at it. They looked at it, and in the board, they decided to change the guidelines in Denmark of 1st of July 2014, so that today in Denmark, this is total hip arthroplasty, we can use these different drugs, and we can use them as long as they are only in the clinic if we are using fast-track setup of our patients. Otherwise, they should be 6 to 10 days. But in my nation, Denmark, I think most of clinics are today running a fast-track setup like we are doing. It's more or less standard. So the next question here, of course, is DVT prophylaxis needed in short-stay total hip arthroplasty? This question, of course, we cannot answer. It's much more interesting to discuss why there are that difference across Europe, which I know there are, which of course is a hot topic to discuss. So my take-home message to you is that in department running rapid recovery total hip and total knee arthroplasty programs with early mobilization, that means the day of surgery, and early discharge, that means within the 6 days after surgery, DVT prophylaxis is only needed during the hospitalization in patients with no prescription of potent anticoagulant therapy for the last 6 months. However, national guidelines and your national guidelines need to be recommended to change before I think you should start doing this. Whether prophylaxis is needed at all in our rapid recovery patients cannot be answered from this question, but I think it's still an open question to be researched. Thank you very much.